Good afternoon, everybody. I'm Steve DeMello, Director of Healthcare here at CITRIS, and it's my great pleasure today to introduce a longtime colleague and friend, Dr. David Lindeman, for our research exchange. I'd like to welcome everybody here today, as well as our folks online. Remind you that the I for Energy talk this Friday, same place, will be on using wireless technology to evaluate building performance, and remind you that everything you have for lunch is compostable with the exception of the aluminum foil around your burrito. For folks who have been to some of our other healthcare presentations as part of the research exchange, you'll know that two of the themes that have sort of been consistently raised are, one, the challenges around providing services and healthcare for an aging population, particularly chronic disease in the elderly. And the second has been the idea of, because CITRIS's charge is not only to help develop technology, but to find a way that it has meaningful use in society, how we move from simply good design and technically correct product to something that has real traction among users and something where we can demonstrate our ability to go to scale, to get widespread use in a way that's beneficial for folks. And I'm particularly thrilled to have David here because his organization, the Center for Technology and Aging, which he's built over the past 3 years, has been exactly at the balance point of those two issues, trying to identify and understand the needs of the senior community and their willingness to engage with technology, but maybe more importantly, to really start to understand what it is that makes technology useful to groups of people and the best models for making them sustainable and scalable for healthcare delivery. As I mentioned, David is the director of the Center for Technology and Aging, which is based here in Oakland. He's worked in the field of aging and long-term care for 30 years as a health services researcher and administrator. Prior to founding and joining the CTA, he was the founder and director of Mather Lifeway's Institute on Aging in Evanston, Illinois, where he was responsible for developing and implementing evidence-based research programs. He is a proud graduate of UC Berkeley, both bachelor's and MSW and PhD, and a bachelor's from SUNY Birmingham. Please join me in welcoming Dr. David Lindeman.
Thank you, Steve. Can everybody hear me across the room? Wonderful. Well, I'm delighted to be here. First, because I've enjoyed and very much been impressed with the work that's done here at CITRIS, but also, as Steve has said, having the opportunity to speak to you about the applied application of technology in a very important cohort of individuals, and that's our aging and older adult population. Today I have a number of approaches that I'd like to take to share information with you about our different activities at the center, but specifically, as was Steve emphasized, take you through a few of our projects and show you what we think is one of the most critical aspects, not only that they have an impact on older adults or the workforce that's helping them, but also that they can succeed in being taken to scale. So with that, I'm going to take you through a number of different aspects of what we are about. First, by giving you an overview of the center itself. Then I think it's important to step back and just give you the context for our aging population today, the tremendous growth in it, and many aspects around not only its aspects of using technology, but particularly its impact within the healthcare system. And then talk to you about our grants program, specifically the Diffusion Grants program and examples from 4 different areas that we've been working on. And finally, some of our takeaways that we have so far from these programs that some have completed, most are still in the field, and what we're learning about how you can best address deployment of technology in a healthcare system and how you can and prepare for getting to scale as rapidly as possible. So to get us started, the Center for Technology and Aging, as Steve said, was created 3 years ago. We were supported by a very generous grant from the SCAN Foundation based in Southern California, whose emphasis is on promoting aging in many areas, from policy to program initiatives. The funding for that organization came from one of the more innovative senior managed care programs that was created here in the U.S. Going back over 20 years ago. We're an independent not-for-profit center and focused primarily on how technologies can help older adults not only lead healthier lives, but stay independent in their own home, stay independent at whatever level of care they may be at. We have worked with organizations throughout the U.S. Our primary emphasis is here in California. As you'll see, many of the examples I'll give today are California-based organizations. 2 years ago, we launched our Diffusion Grants program and have, over that period of time, put in $2.2 million for 22, as we call them, learning laboratories. Different individual grants and projects that are taking on specific proven technologies, not technologies that are being developed or have not been used before, but proven technologies and applying them in a new setting or in an expanded setting. The focus areas that the center has been looking at range from the 4 that we have been using for our different grant programs: medication optimization, remote patient monitoring, health technologies, and also programs that are focused on changing care transitions. But we've also been considering different technologies around assistive training, particularly in a remote distance for individuals who are working with older adults, cognitive fitness, and social media. But I'd like to step back at this point and go back to that 50,000-foot level and put it into a different context. I'm going to be speaking about chronic care, about frailty, about impairments, yet I think it's important to start with the positive side of aging and how technology is used by older adults in so many ways, whether it's from a wellness perspective, whether it's communication, whether it's social connections. There are quite a few different issues that people don't realize with this very exciting and growing population. I'd just like to give you a few statistics that have just been published late 2011 and 2012. In terms of cell phone ownership, in the U.S., the older adults now, those who are 50 to 64, the boomers, and those who are 65 to 74 years old, have over 75% use of cell phones. And in the case of the 65 to 74, it's actually 82% of those individuals have cell phones. Tablets, more recent phenomena, one that one might think would not have penetrated the older adult market. In the last year, just in 2011 alone, the number of individuals 50 to 64 using tablets doubled from 8% to 15% of all seniors. And those older growing at the same rate, even though it is a little bit less. In terms of social networking, if those of you who haven't followed this, social networking has had the greatest increase proportionally in the older adult population over the last few years. From 2009 to 2010, those individuals 50 to 64 using social technology, social media have gone from 25% to almost 50%, almost half of older adults, and are now using some form of social media. A few other final statistics. In terms of individuals being online, it's intriguing to see that while in the U.S. population, it's almost 80% of people who are online on a regular daily basis. For boomers, it's almost identical, 78%. And for seniors who are 65 and older, 42% are online every day. Using search engines, the same relative proportion, 60% for all U.S. individuals. For those who are 65 and older, 37%. And those who look for online health information being one of the biggest issues that elders use our technology for, we are seeing that in the general population, it's almost 60%, almost 3 out of 5 individuals. But in the 65 plus, it's already reached 30%. It's very intriguing that often when we look at these issues, we just think of there are very much, and I hear it all the time, the specific myths of older adults not being particularly computer savvy, technology oriented. For the most part, one has to, like you do with the older population in general, have to look into the details, look at the heterogeneity of our older adult population. It is true that the old, which we consider 85 plus, are far less active in terms of using technology. Also, older adults in general are late adopters. On the other hand, the potential and the use and the rapidity which older adults are now moving in this direction for all sorts of positive aspects of wellness and well-being are tremendous. The rest of the session today, I'm going to speak to the information, though, around that percentage of the older adult population that's at risk, that needs care, particularly around chronic disease, because this is an even growing, ever-growing part of the population that we need to be aware of, and I will show you just the impact that that smaller cohort is having on society, on our national budget, on the quality of life for our entire society overall. So just a few additional statistics to give you the context. We are seeing a tremendous age wave. Just starting with the first boomers turning 65, 10,000 are turning 65 every day. That's 1 every 8 seconds. Over the next 20 years, we're going to see a significant increase in the number of individuals 65 and older, going from 40 million to 70 million people. And for the first time, while we've seen gradual increases in the relative percentage of those who are 65 plus, we are now going to see it jump from 13 to 20% in just the next 2 decades. The group that's even more at risk for needing health care and other services, the 85-year-old population, is growing at an even greater rate. It'll be quadrupling over the next 40 years. And to make clear, there is a tremendous impact here in terms of how much this costs society just around healthcare alone. The figures speak for themselves, the average being many times greater, the need for healthcare and the cost of healthcare for older adults than children or adults of working age. When you couple this with chronic disease and the impact that chronic disease has on our society, we see an even greater need for solutions. 90% of older adults have 1 or more chronic diseases. 50% have 2. The numbers go up even more for those who are older or have severe chronic impairments. A few specific disease categories are incredible in their own way in terms of their impact. For example, 27% of older adults have diabetes, and one of the largest issues that older adults are dealing with, congestive heart failure, it drives 43% of Medicare costs today, and that will be going up. So in essence, the issues around chronic disease, and with a particular emphasis on older adults, accounts for 70% of our entire U.S. healthcare budget. But putting these two together with a few other factors is important, because it's not just the magnitude of the size of the aging population, it's not the magnitude of chronic disease and its impact, but when you put that together in terms of the total cost of healthcare overall, and then couple it with what's happening in terms of the workforce, where we have a shortage of 50% of geriatricians currently to serve our aging population. We're in need of a minimum of 100,000 direct care workers to work either in home health or skilled care communities just over the next few years to try to stay even. And then you put on top of that the family burden for caring for older adults. There are now 42 million family caregivers in the U.S. who are taking care of a person 50 and older. This is a tremendous burden, not only for them from their family perspective, but a drain on society, a drain on the businesses they work in, and clearly, at minimum, a challenge in the quality of life for both older adults and the family members themselves. So this is where technology offers a specific opportunity to really make a difference, to be a game changer in this space. And as we're looking at what the charges are across the U.S. now for the healthcare system with the triple aims of creating better health, better care, and reduced costs, we're clearly in a wonderful position to take advantage of the work that you folks do and that others in this space have been doing in terms of leveraging technology to great effect. So the approach the center has taken over the last 2 years has been looking at how we can deal with improving care delivery areas, how we can address these chronic care conditions, and how individual organizations who are in alignment with this mission, who need to do this, not only want to, but need to do this to advance the programs, address the cost pressures that are now before them, but truly, ultimately, improve the well-being and outcomes, health outcomes of older adults, what they can do. The approach we've taken was to start a Diffusion Grants program, one where we have targeted 4 different areas to date, and these areas were selected, I'll give you the rationale and the basis behind each one, that have an immediate impact on how healthcare can be delivered to the aging population and how it's having a critical impact on our society. In each case, we're looking at organizations that have experience with technology, have already tested out, if not the technology that they submitted or promoted, but have a history of being able to take their programs rapidly to scale, or the potential for showing other organizations around the country and how that's done. We, as you'll see from the grantees, I'm going to take you not through all 22, but give you a few specific examples from the 4 areas. You'll notice that we have worked with organizations that deal with people at home through home care agencies. We've worked with organizations that are in senior residential programs. Now they're helping their older adults live in that situation. And we're dealing with large healthcare systems and hospitals who are dealing with the issue of reducing readmissions, managing medication, having to deal with the issues of moving people from acute episode of care back into the preferred place of choice for where they live. The rationale behind this, as I've been alluding to, is not only seeing efficiencies in healthcare delivery, but how we can better manage chronic care conditions. Technology offers numerous ways to do it, and I know that several of you are working on some projects related to that. They can clearly lead to the most important issue, which is improving health outcomes. But lately, and it's very obvious from just tracking the media, that what's driving healthcare are the costs and how we can reduce those costs. And we're looking at technologies that, as great as they could be for improving healthcare outcomes, if they don't reduce costs at the same time and improve efficiencies, they're going to be very hard to spread and diffuse through our healthcare system. So what our ultimate goal is on each of these projects has been to see how quickly and rapidly they could adopt and deploy their programs, but then could they, in the course of these initiatives, scale them? The grants themselves have been approximately $100,000 each. They're given for a 1-year period of time. It's a very short, fast ramp-up period for organizations that often don't move that quickly. Many of them have had significant challenges, particularly in doing rigorous research, everything from dealing with human subjects and their IRB situation to having to change technologies in the middle of a project. We have seen some wonderful examples of people grappling with issues and succeeding. We've also had several of the projects not succeed, and that has given us just as much information about what works and what doesn't work. So with that, I'm going to take you through each of these 4 areas. I'm going to give you background on the problem or the rationale for why we've looked at each topic, give you a quick overview of the 5 or 7 organizations that are working in that area, and then highlight one organization in each case to give you a feel for what they've done and what we've learned so far from them. So Our first area that we started 2 years ago was focusing on medication optimization. The whole gamut of how medications can be improved, whether it's medication dispensing all the way through to adherence. What's important in this area, particularly for older adults, as you can see, is that all older adults, almost universally, are using medications. 90% of older adults have at least one prescription medication for a chronic condition. 41% of older adults take 5 or more medications at any one time, and over 10% take 10 or more medications at a given time. The impact, as projected by the New England Healthcare Institute, is dramatic on our society. On an annual basis, $290 billion are spent inappropriately on medications, just in medication adherence alone, much less all the other aspects of how we deal with medication. And giving it a real personal touch, the direct impact for older adults is staggering. Not only is it reduce quality of care, inappropriate care, create more additional comorbidities or healthcare episodes, but it results in over 125,000 deaths a year from inappropriate use of medication. We selected 5 very different organizations in our first round of grantees, ranging from associations to the VA. They worked on from home health care to working with senior living organizations to working with individuals in their own home. I'm going to focus specifically on Connecticut Pharmacist Foundation, and I do have a video, but I think in light of time, I'm going to just take us through this because I want you to see each of the different examples, and if we have time at the end, I can play that for those who are interested. The Connecticut Pharmacist Foundation is responsible for setting policy and coordinating the work of the entire state of Connecticut's pharmacists. They have a number of innovative programs that they've implemented, and the one that they brought forward to us to look at was one that focused on a very narrow set of older adults, and that's older Cambodian Americans who, for the most part, almost universally have come to the U.S. after experiencing the tragedy of going through the Khmer Rouge period in Cambodia some decades ago. Not only did that have a tremendous impact on them, but they already do have preponderance for higher chronic illness, have a number of different social issues against them, both economically, their literacy rate, et cetera, have all worked against them. There are, in fact, several large areas within the United States where many have settled, one being Connecticut, but also here in Southern California, in the Long Beach area. The Connecticut Pharmacist Foundation found that they not only needed to reach out to this group of older adults in a new way, one where the older adults were quite often fearful, much less had a great deal of difficulty understanding what the pharmacists were doing, but also reaching out to them in an efficient way. They turned to video conferencing, to which they added a spoken format technology, and were able to also link in electronic medical record data so that pharmacists could get this information on a regular basis. They created a remote pharmacist visit concept where a community health worker did join the older adult so that there was translation available and a person who could help them show the medications and deal with the specific issues around what they were taking, how they were taking it, et cetera. The long-range goals for the program were both to reduce different types of healthcare utilization, clearly improve and manage individuals' medication use, but in a population that was not taking their medication correctly, making sure that they did start using medication on a regular basis in a proper manner. The program was, on the programmatic side, was significantly successful. They increased their ability to manage medication problems almost universally. 93% of all problems were solved in this method. If you look down below, the virtual medication therapy management program that they created was equally effective as having a pharmacist meeting with a person face-to-face. So it clearly created an ability to reach out to many more individuals by fewer pharmacists. And there were improvements from adherence behavior, which was a key outcome in being improved by 23%, to reducing inappropriate medication use and even improving, reducing depression, improving the emotional state of the individual participants. One of the key takeaways for the program was its return on investment. And I'm going to come back and discuss this with a few of the other programs, because we've learned that return on investment is one of the key metrics that healthcare organizations turn to, regardless of how great it may be in terms of improving quality of care. No matter how excellent healthcare outcomes can be, and even well received by both patients and providers alike, when you're dealing in healthcare systems today, it's how much does it cost, how much cost avoidance can we get. And in their case, they determined that they were saving between, for every $1 that they spent, they were saving $5 to $6 in terms of overall healthcare. But then we get to the crux of the matter in terms of scaling and sustainability. This very successful program that showed all these examples within the last year and a half has now run up against the wall. In terms of taking this program to scale, much less getting the healthcare systems within Connecticut and California to use it, they've hit one of the primary roadblocks, and that is this program does not have a business model or a reimbursement scheme that supports it. Currently, Medicare and Medicaid have not been, will not reimburse for pharmacists doing work long distance, no matter what the success of this program is. Here, the good part is they have spent the last few months with, and now have legislation before the Connecticut legislature to approve this type of care and have it reimbursed through Medicaid. So even when you see successful programs, it's putting it in this context of how do you then take it to the next step. The area that we've had the greatest uptake in, and because we've seen, I'm going to give you some examples of just how effective this has been over time, is remote patient monitoring. Remote patient monitoring is not new. It's been around for a long time in different forms. You can see many of the different benefits that it has, from reducing emergency department visits or hospital services, all the way to improving how care can be coordinated for individuals. But it has not yet advanced in the scale or that one would expect, given the benefits that it has achieved. The 5 primary areas where we do see remote patient monitoring being used in terms of improving healthcare are heart failure, diabetes, chronic obstructive pulmonary disease, medication adherence, and asthma. CHF, heart failure, COPD tend to be the 2 that we see used more likely than not, because through the use of just a few peripheral devices, weight scales, blood pressure cuffs, and getting that information back to a base area, you can monitor individuals very easily at very low cost. What's intriguing about this, particularly from those of us who are interested in scaling, is why hasn't it yet been fully adopted and used in all healthcare systems or by physician groups around the country? Why is it hasn't been built up to the level that one would expect with the evidence that's out there? In the last year alone, the 3 top studies that I have listed here have proven the case almost definitively. Geisinger Health Plan just in the last month released information about how in their large system, one of the most prominent systems in the country, creating an accountable care organization at this point, had a tremendously successful run with introducing remote patient monitoring, resulting in 44% reduction in all-cause 30-day readmissions. A huge improvement for older adults, and clearly a huge cost saving for the health system. Just a few months ago in the UK, the results of their whole system demonstrator program were released with a great splash, because the NHS realized that this is going to give them an opportunity to make even greater inroads in reducing the cost of care and providing better care to individuals in many locations throughout the country. Their study, which is still ongoing but is a randomized controlled trial, actually showed the results that you see there, significant reduction in mortality rates and reduction in the other areas of healthcare utilization that are important in this area. The UK, the NHS, the National Health System, presented these findings with the announcement that they expect to roll remote patient monitoring out to 3 million people over the next couple of years. Now, whether that will happen and how they do it, we'll speak to that as you hear the other results. Again, even last year, the best CMS, Centers for Medicare and Medicaid Services demonstration using Health Buddy, a small device that allows individuals in a home to record or answer specific questions, came out. A study that was done in Washington State and in the Bronx, and the key takeaway, the aha moment for all people who've been waiting to see this, was that it did create a significant reduction in costs, up to 13% per quarter per person. But the be-all and end-all in terms of this area, to give you a sense of what the possibilities are, really comes to the work that's been done in the Veterans Health Administration in the VA here in the U.S. The VA has been at this for a number of years. They are the early adopters. They have deployed telehealth in conjunction with care management, woven together in such a significant, basic way that they are now having a tremendous impact on how and where veterans are being cared for. The VHA, for those of you who don't know, has gone from an organization that often was denigrated for its healthcare system in the decades past to one that is really in the forefront of managing care, coordinating care, and doing it in a uniform way on a grand scale. Their programs, just over the last 10 years, and with data that they collected back in 2007, have reinforced this issue about how remote patient monitoring can be used to reduce bed days, admissions, and be very high satisfaction, not only for patients, as the 86% represents, but for providers, physicians, other care managers as well. They have moved this to the greatest scale of any organization in the United States. Over 65,000, as of last month, individuals at any one time are using remote patient monitoring. It's being done on a national basis. They distribute the devices in an organized way throughout the country from a base in Denver, and it's used on the local level to extraordinarily great success. So we wanted to see what would happen in this area with some of our grantees. But just to show you two last points on the VA, it's important to note that they already know from their results just how effective this can be in terms of reducing costs. Normal cost for their system, having the remote device and a person monitoring it and working with an older adult, costs only approximately $1,600 a year. For that same person, if they're in working, going back and forth and having primary care visits and other problems, it's a minimum of $13,000. And if those individuals, many of whom would be eligible for skilled care, SNF care as we would call it, in a nursing home, the cost would dramatically jump to $75,000 plus a year, which is, that's at the federal level. The average cost for nursing home care on a private level now is even greater. And the VA, once again, did this in a very systematic way. They have put all this system together. They've organized it in a very formal way, and it's now done through a very specific protocol. We looked at 7 different organizations, ranging from home care organizations to specific hospital and health systems. They've each used different types of devices. They've focused on different diseases. And I'm going to just mention 2 briefly. the Centura Health at Home program, which provides home care in Colorado, where they used these devices but built them out, created not only an improved system for this care, but did it with a new call center, and added to it risk assessment so that they could identify those individuals who needed specific types of remote care support so that they could target their individual work. The results are striking. They had a 62% reduction in rehospitalizations, and the visits that were really are the highest cost aspect of individuals going into an older adult's home to monitor them from 2 to 3 a week dropped to less than 3 for over 8 weeks. Interestingly, they were the first program to finish. They did their project in less than a year. They are now ramping up in a number of ways, not only how they have created a 24/7 program, but they're now taking this from the community into senior living communities, residential programs, and they're expanding it statewide. But one of the takeaways that we love to see was that through their efforts, they actually had legislation introduced this last year that was passed that now permits this to be funded under Medicaid throughout the state. And there are only a few states that do that. Another program closer to home is Healthcare Partners, a large physician group organization down in Southern California, who took a different tact on this. While Centura looked at congestive heart failure, COPD, diabetes, Healthcare Partners focused on COPD alone. And they did it through an interactive voice recognition system, one that was very basic but had made tremendous difference in the well-being of older adults and their ability to track who needed care on a just-in-time basis. Their system was created for them. This is just a quick example. The dashboard and reporting, very simple approaches. Those that are red indicate that an individual is having a difficult day and needed to be monitored carefully. And when translated over to the other table, it allowed nurses who are monitoring those individuals to target and zero in on those who needed greatest help immediately so that there was not an acute episode or people did not have to go to the ED or become hospitalized. So what was intriguing is that as the RNs focus on these individual groups, they were able to narrow it down to 5% of the population that they needed to put their attention to at any one time. They are still in process. It's going to be very interesting to see how they expand. This is a very large health care system. They have over 20,000 COPD patients. They're looking at this initial information has been very well received, and they're now participating in what we are doing in a broader area, our return on investment study. Because as I mentioned earlier, a key driver for whether it be large physician groups, health systems, hospitals, is the fact that they need to demonstrate, no matter what a Geisinger has done, no matter what the VA has done, they need to see for themselves what the potential savings will be for them in their system. We identified that as a key issue, and we're very fortunate to get support from the California Healthcare Foundation to work with the Center for Connected Health at Partners Healthcare over in Boston to develop a new ROI tool, an ROI model that can work across different care settings, but allow healthcare organizations to determine, as they plan to roll out a specific RPM device in a specific setting with a targeted population, what the potential return on investment will be. To date, we're doing it with 5 of our grantees, and it's working relatively well. In fact, we are now in the process of seeing how this can be put up on a web-based platform so it can be universally accessible. Last 2 areas that I'd like to cover as we're pushing time here, and that is one of the key drivers that we identified beyond medication, beyond dealing with remote patient monitoring, has been an issue that's come to the forefront of healthcare in the last 2 years. And that is the tremendous expense, and inappropriate use of hospitalizations, particularly those that occur after an individual's been discharged. 1 in every 5 Medicare patients is discharged from the hospital who's been discharged from the hospital gets readmitted, and often that's within the very first week, within 30 days of discharge. Most of these, 3/4 of them, are preventable. The cost savings, again, to our entire healthcare system and society, just on an annual basis, could be $25 billion if we can get a handle on this and reverse it. So there are a number of ways that this can be improved, everything from working more closely with individuals as they are discharged from the hospital, how they are followed up, how they are managed, and this is where technology can come in a very big way. Everything from identifying high-risk individuals before people leave, to the monitoring we've talked about, to even helping people understand through technology how they can take better care of themselves. In this project, we were very fortunate. We were approached by the administration, U.S. Administration on Aging, who is working with the Centers for Medicare and Medicaid Services to work with their programs called Aging and Disability Resource Centers to see if we could find, or they could find, mechanisms to help in improving this discharge process, reducing the amount of time that it takes to get a person well into care management and eliminate those inappropriate readmissions. The program worked with 5 states, and we are in the process now of collecting information. The first one, out of Texas, had some excellent findings because they worked on a well-known, tested care transitions intervention program that is put out by Eric Coleman, who is also a Berkeley graduate who now works at University of Denver, and they were able to work at putting technology applications to bear on what is a very hands-on process of helping people manage themselves back in the home. Long story short, their work in less than a year was not only so well received by their compatriots in other areas because of the immediate cost savings and ability for efficiencies where it could save close to $1,000 per week for each organization. It rapidly expanded from Texas to being operationalized in 21 different states. And finally, I get to our last area, mHealth. And this was not built around our concept, not building it around a specific care management process because, as you all know, mobile or connected health is ubiquitous in many areas of healthcare, from wellness to chronic care. And yet it is one that's advancing so rapidly, it has so much potential that we wanted to see what organizations could apply their newfound or experience in this area to this issue of helping older adults stay independent and taking them to scale. So once again, a little context now that we have nearly, not only half of Americans have smartphones, but smartphones are now outnumbering non-smartphones in the US just this last year. By 2016, just a few years down the road, over 1 billion consumers will have smartphones, and this year alone, we anticipate the number of health iPhone apps to jump to 13,000. For our particular purpose, though, it's really, what's really exciting is that several organizations, including the Boston Consulting Group, have projected that mobile health alone, but whether it be apps, whether it be giving people information where they are through text messaging, on and on, can contribute to a reduction of 25% of the entire costs of healthcare for older adults. We funded 5 organizations ranging from a county organized health system to a senior living community to Health Insight, one of the 17 federal beacon communities, which is responsible for bringing healthcare information across an entire system in a community. The closest beacon community here in California is in San Diego. I'm going to just mention what Health Insight has done because they've taken a very good approach where they've looked at the specific program that can be a population managed program that using text messaging to help individuals dealing with diabetes. Taking a program that has been pushed out throughout parts of Mexico, applying it here in the US in English, enhancing it with standard clinical protocols that are well adopted by the Diabetes Association and Institute of Medicine here in the US, and putting it in a basic two-way text messaging program, and also using a web portal for providers and patients. What was exciting about this is they went to community clinics, and not only to work with individuals from a population perspective, but because clinics are so expansive in the Salt Lake City area, going out to 50 of them immediately to see how well the uptake of this would be. And uptake is by having individuals, not providers, but individuals, use this application on their cell phone. The specific items that it works with are looking at basic issues that are needed in diabetes management, monitoring your glucose measures, but also giving people educational messages and tips. Those are examples of the messages people would get, and they're targeted based on what individual's protocol is. And there's another example of the web portal in terms of what can be tracked. And here is an even more advanced one that shows both for providers and if an individual person with diabetes gets on their computer or goes into the clinic, can also monitor these different issues around what their goals are, particularly if it's weight management or managing medications, which are critical in this state, can track these on an ongoing basis. We're still in process in this. These types of text messaging protocols, I'm sure you're all aware of, and they're advancing in different disease areas and categories, not only in aging, but we're seeing them ramp up and modify very quickly. But this is one of the first cases where we're seeing it being taken to scale quickly with a large number of clinics. Key takeaway for this program is they have really had success at this point in terms of what we consider one of the holy grails, and that's getting patients engaged. Patients are responsible for using this. It's not being pushed to them. They take it, they use it, and they have to be the ones who take full advantage of it. Well, I'd like to wrap up by talking about just some of our overall findings, because, as I said, it's not just improving care and seeing how we have better health outcomes, reduce costs, but it's how do you get improved deployment, how do you improve scalability. What we've learned from many of the programs to date right now is, I think, this one key takeaway, that it's not just the technology. In fact, we think technology is the easier part for many of these different types of healthcare issues, but it's all the other elements that go behind getting technology in place. Starting with having a champion on site, organizations that you do have to go through a great deal of change to implement these, so understanding what change management is about, getting buy-in from both staff and patients, getting them engaged in this, so whether it's the user interface or it's the what's going to benefit the staff has to be brought forward, and understanding workflow processes and having good strategies for getting that pushed forward. And in terms of scaling and sustainability, key issues that we see, some of them are not rocket science, but just the ability to start rather than start with the technology, it's looking at how you align what you're doing with the organizational goals and care processes that one wants to address. Secondly, around business models and return on investment. Again and again, we see that coming back, that people go into these projects, some that we've had, with great concepts, but what they thought was going to be a great way to ramp this up or work this through from a business perspective just didn't work out. So again, being able to look at that at the front end rather than after one's done a pilot or introduced this. And finally, being able to do some of the things we just mentioned, having programs that are engaging consumers and the providers from the beginning, but are also sensitive to the other major player in the healthcare space right now, electronic medical records and health information exchanges, and how these can link together. Fortunately, in California, we just had legislation passed that is making it much easier for many of these programs to go forward through AB 415, which has changed the way we can use telehealth and other forms of health care delivery that had not been allowed in the past. So in conclusion, we're at a point now where we're trying to synthesize this type of information, put it together in a conceptual framework so that we can put together these takeaways. What are some of the central items that are universal for organizations as they're looking to implement programs or take them to scale? What are some of the key pain points that people need to look at? But I want to reinforce, we start with the older adult at the center and build it out from there by collaborators who are considering the entire provider and healthcare system and putting it into the broader social and regulatory and healthcare reimbursement context at which we're dealing. But that will be for another time, and I know that we're pressed for time, so I'd like to open it up for questions. Thank you.
So do we have any questions?
We have time for a couple of quick questions.
Sure, go ahead right here.
Well, this is, okay. Thank you. This is about one of your figures about cost savings, where you were comparing the cost of the home monitoring at $1,600 a year to the cost of skilled nursing care at $70-something thousand a year. And I was a little confused by that. Does that mean that if the person were not able to have the remote patient monitoring for this one chronic disease, that person would then be living in a nursing home? Because and if that's the case, then it seems like it's still kind of a strange comparison because you're getting so many other services in the nursing home. I realize this is kind of a picky question, but I wanted to get your take on it.
It's an excellent one, and one that's raised all the time, trying to isolate these specific factors out. Those are the figures that the VA had used, and in terms of specifying just what that program by itself would be versus the extreme of somebody in a skilled unit. And yes, not all individuals would be nursing home eligible or skilled level of care eligible who are using those programs. But the average cost that they looked at, which was using remote devices, bringing them back to a care manager, and all the underlying infrastructure behind it, was averaging out at a very low rate because of the efficiencies they could do. And it was able to avoid what does occur, people having to come into from a long distance for an emergency visit or to go see physicians, et cetera. So they're trying to just point the comparisons in those extreme cases. But you're right, there are many other factors that should be considered in it.
Okay.
So first of all, I'm looking forward to the reduction in healthcare premiums that will result from all this. I'm not holding my breath. But a question is, to what extent does the lack of standardization in information technology in health records impede the deployment? Because the NHS can do this for $3 million because they have one record system. But you're talking about piecemeal adoption by hundreds or thousands or tens of thousands of separate organizations.
Absolutely, perfect question. That's one of those $64,000 questions, and it clearly is a major issue, ranging from just the variations we have in electronic medical record systems, the variations in health information exchanges that are trying to deal with this. A whole international community based around the organization called Continuum, which is trying to build interoperability standards. Because when we talk about, you just take remote patient monitoring, devices that are, not all of them are built agnostic and do not function within different systems. Just at those levels, and being able, since each device maker seems to want to use a different protocol, not having those universal protocols, not having necessarily electronic health records that speak to each other, you're absolutely right. This is still one of the key areas, and why many of these programs are still often in silos, even within their own institutions, because they haven't yet gotten to that point. But there's huge progress being made in this area just in the last year or two, and those are the underlying goals of most of the EMR and HIE efforts.
You had given us an excellent overview of how proven technologies need to be diffused into the environment around. But I have a question regarding technology adoption as such, or technology development. Even when a technology is proven, it has its own high cost initially. And do you see Medicaid subsidizing those costs, or how does that technology cost get split between Medicaid, the hospitals, and the patients?
Great question, and that's, again, one of the $64,000 questions about how will many of these technologies that can be more costly, yet result in good care, how are they supported? Is it through cross-subsidization from different one program to another? And that's usually why we turn back to this return on investment, why organizations, particularly as we move forward over the next few years, as we move to a more universal managed care approach, where people have a limited amount of money and are going to be responsible for providing all of that care for less resources, making sure that you don't have one that pushes another, but that if it does contribute to the overall ability to reduce costs and improve care, then it could be acceptable. But it's the fact that programs are going to be held accountable, and why they aren't being accepted if their price point or their cost point isn't low enough to for the results that you need. So that's going to be an issue that's going to be front and center for this for the next number of years, and really helps drive why some of these programs aren't being moved out quickly.
If I could add one thing to that, one of the trends we're seeing is among technology developers, the need to do their own clinical trials with payers up front to demonstrate the reduced utilization and demonstrate the reduced cost. So folks that 5 years ago would have seen the beginning and end of their process being developing the technology are now having to go the next step of doing sometimes multi-year, effectively clinical trials in conjunction with payers to demonstrate the benefit first before being able to take it to the broader market. And the best example of that is a local company now bought by Robert Bosch Healthcare that did the Health Buddy early on in their experimentation. They literally went out, sought out Medicare to do a multi-year trial as the best way of getting long-term diffusion, was getting the proof. And that's a real difference for technology companies now. Thank you all very much. Dave, if you're around for a couple more minutes, we can probably take some questions offline. But at this point, we have to end the session, and we thank you all for coming today.
Thank you.